Good afternoon everyone and welcome to today's webinar. Thank you for joining us. We are still waiting for a few more people, but they'll probably join in as we go along. Today's session, Prevention in Practice, is the third in a series of 5 that the Improvement Foundation are running thanks to SA Health. So just a little bit about the Improvement Foundation before we start. We are a national not-for-profit organisation based in Adelaide, and we have several staff all around Australia. We have worked with thousands of health services to implement quality improvement initiatives and programs with the aims of improving the care that's given to patients, looking at population health, and supporting practices and improving the care they provide to their patients. So on the screen in front of you are today's learning objectives, and I'll just give everyone a moment to have a look at those. I'd now like to introduce Dr. Ralph Ordham, who is a Melbourne GP. Ralph has been practicing for a number of years and is passionate about providing good chronic disease management and prevention to his patients. Excuse me. Ralph was the clinical lead on 2 collaborative programs that we ran a couple of years ago, and he's also the chair of the expert reference panel for the diabetes topic. So Ralph, over to you.
Thank you very much for that introduction, and thank you for allowing me to talk about this interesting topic, which is goes to the heart of what we do in general practice. Okay, so as to the usual acronyms in general practice, ARAs, DRATs, which are, as one of our, Richard Bills would say, just more acronyms that we use from time to time. But these are really, really important, and I would like to certainly concentrate on how we can actually make effective use of the current tools that we have. What they are actually, the absolute risk assessments, and I certainly am a very big fan of the absolute cardiovascular risk assessment tools, diabetes risk assessment tools. And what I'd like you to reflect on is actually who's actually doing them within your practice. Because I think working out where these things happen and how they can happen is really important. If you have a process that actually embeds that within your practice, it will certainly help. And then, of course, how do you record it? Because a lot of our software don't have specific places to put in your risk assessment tools. And, I'm forever putting it in my warning sections, what the latest absolute cardiovascular risk assessment is. Now, where I'd like to go is thinking about sort of people who we see. This chap, Ralph, funny enough, is, a typical patient that certainly I would see within my previous practice. So he's 67, he's had diabetes, or got diabetes, he's had two separate heart attacks, he's now got heart failure, he's already in stage 3 renal failure. It's having a huge impact on his life, it's limiting what he can do, he's miserable, not enjoying life. As, people with heart failure, they feel tired, they feel, short of breath, and he's overweight. When a new patient comes in like this, there is a limited amount that we can do. We can spruce him up a bit, but we're not going to fundamentally change the underlying problems, which is why we always start talking about working earlier and earlier. So really, for this chap, what we're talking about is secondary prevention. You may even, depending on how he looks, start talking about advanced care plans. And, if his heart failure is really bad, you may even start talking about end-of-life care and palliative care. And certainly the fact that he's miserable, not enjoying life, we know depression in this cohort of people is very high. And we need to be thinking about how we screen for depression in people with chronic disease. So important for him now is, trying to improve his lot in life. And like I say, in many ways, you're not going to make a fundamental change, but you can certainly improve some things. A lot about secondary prevention. And where I really want people to think about is those critical times that you can intervene. So he's had 2 heart attacks. After someone's had a heart attack, do you automatically put a system of care around them? Do you review them all? So, our practice is if we get notification that someone's in hospital with a heart attack, we actually make an appointment, usually within 1 or 2 days of them being discharged from hospital. And I think it's really important to capture them at that time and, implement a care plan, because often these people, they're a bit overwhelmed. And, when we're looking at our data from my previous practice, we had 80% of our people with heart disease on care plans, which I think, is a fantastic outcome. But look, if we wound it back a little bit further, so again, it's all about when you intervene. 5 years previously, he was newly diagnosed with type 2 diabetes. He had his previous heart attack. He was still smoking, but, he's working and he's drinking too much, So then you start thinking, well, what would be doing at this? Now, the fact that he'd had a heart attack previously, we knew already that he was at a high risk of getting type 2 diabetes. So did we do an intervention after that first heart attack to talk about his risk of diabetes? He's obviously taken some of the health messages on board, because he's gone from a 30 cigarettes a day down to 10. And he's still actively participating on the roads, in terms of working. So, I think we've got quite a bit to work on here, and he's been through quite a bit, so I still think we can intervene and intervene very effectively. So, for this guy, it is still talking about secondary prevention, because he's got his heart disease, he's got his diabetes, and what we're talking about now is trying to improve and prevent further complications. But of course, roll it back even further, because a lot of what he's got is actually preventable. So there he is, the handsome chap, just out of hospital. He had his first AMI. He had 2 stents put in. He was smoking 30 a day, still drinking fairly heavily. He's overweight. He's now on 5 medications from nothing, so, that's a big jump. And he's feeling overwhelmed and he's overweight. So, after a significant event like that, it's often a great time to get in and intervene and wrap around him supports, whether it be, practice GP, practice nurse, maybe something to do with exercise physiologist, talking about, the cardiac rehab programs. And we know these things aren't being done for whatever reason. So, when we talk about cardiovascular real cardio rehab programs, in Victoria, only about 35% of people who have a heart attack or have a stent actually end up going to a cardiac rehab program. Yet we know it will decrease mortality over 5 years. It's about, I think, somewhere between 30 and 40% just by attending a cardiac rehab program. And there are all sorts of reasons for that. But I can tell you the hospitals are terrible at referring people in. So, again, a lot of that will fall on us, which is why, again, as soon as someone's had a heart attack, I like to get them in and start to talking about what their experience was, what they understood by this. And the good thing here is that the care planning process allows you to do it after a significant change. So it's a great time for this guy to sit down with my nurse, for half an hour, 40 minutes, and then sit with me for 20 minutes, half an hour, to actually talk and sort things out. And it's that time that becomes really, really important. And then what we tend to do is ensure that that care planning process stays in place. So, if someone's like this who's smoking, we would continue to see him 3 monthly because, we've got a lot of issues. We've got his smoking, we've got his drinking, we've got his BMI, his recent ischemic heart disease, and I would see him 3 monthly for a review and then another full care plan at the end of 12 months because, again, we need to be tackling it and making sure this guy feels supported. But even if we roll back further, and this to me is where the challenge is. So there he is, he's 48, he's a heavy smoker, drinks heavily, he works on SA roads, doesn't do much exercise apart from, getting on and off his big, bulldozers. Doesn't like vegetables. He's got 3 children. And look, he's overweight. But, capturing these people can be quite difficult. As a doctor, we may only see him, when he's coming in for a certificate. He may have a chest infection. And you can certainly do things within a consultation. The brief interview. We know that if you mention, even just say, about cigarettes, have you thought of quitting or cutting down? And if he shuts down the conversation very quickly, that's fine. But you've at least mentioned it. And we know just mentioning it makes a big difference. We can certainly tackle the alcohol. And so the question is, how do we make this chap aware of what's going on? And so, a lot of our patients, certainly at that point in time, he's young, he's fit, or from his point of view, he doesn't see that there's a risk. He doesn't see a problem. He's not feeling anything. And so how do you actually engage in a person like that and get them to understand what the risk is? And so fundamentally to this is actually, how do you motivate people to change before there is a problem? And I mean, we all struggle with this. It's not everyone who gets the message, but a significant will with a brief intervention. So for him, how do you get your message across? How do you get that message into action? How do you measure whether you're getting there? How do you even start with all these things? And there are so many things that we're being asked to do, every day. Oh, yes, general practice will do more and more. But if you look at his passage, his journey through, the time where we first saw him before he developed anything, to where he was at end stage, these are people that we look after. And certainly, I'm a cradle-to-grave GP. We have a lot of people who will keep coming back to us. And, if you start thinking, that there is a responsibility that we have to support our patients within that journey, if we don't actually support them, they will end up going down that pathway time and time again. So allocating time to that becomes really important. And, it's always important that we make it financially sustainable. So in my previous practice, we were a bulk billing practice, so it's not like we can charge people. So, we were very low ES, high rates of unemployment, and so we had to make, really important good use of, the health assessments and the care planning items. And so you'll see that he's 48 because within that there is some health assessment funding that we can use, and I'll talk about that later on. So, and then the key element is, how do you make it part of your everyday practice? So in my current practice, every new patient comes along, and I'm sure a lot of you do it, they have a questionnaire that they fill in. And, down the bottom it says, do you smoke? How much? Do you drink alcohol? How much? And it's just a great way of just scanning when you see someone for the first time and, talk to them, just prompt them a little bit. We know brief interventions can make a huge difference. And then once you've sort of identified them, you can offer them things like, well, if you, want to explore this, there may be a family history of heart disease and he's a smoker. And you may say, well, we do have a service where we can assess you about your risks of heart disease and diabetes, and what we can do is some blood tests beforehand. It starts to become part of a usual part of practice. Mind you, our nurse is very heavily involved in that, which we'll talk a little bit later on. So, for this chap, you can do certainly your absolute cardiovascular risk. At that point in time, with those figures, he sits at around about 11%. So, he's in that sort of intermediate risk where, certainly starting with lifestyle is really important. You can do your diabetes risk assessment. These are all sort of available on the web, and actually giving them copies of what they do. I find the absolute cardiovascular risk assessment absolutely key. And, you know, when you start talking to them about, well, you know, you're at high risk, they suddenly stand up and take notice. But I've also used it in people going the other way who think they're really at risk, and you say, well, no, in fact, you're doing pretty well. You need to keep doing what you're doing, and it goes very well. But as you can see, there's so much that we can do. You know, your FRAX, which is, you know, risk of, you know, having a fracture over the next 10 years. You know, screening for AF. You know, this is so important. We know that atrial fibrillation, you know, is under diagnosed and also probably undertreated. So, you know, thinking about, well, how am I going to do this and do this in a practice-wide approach? So, you know, ideas like, well, with the AF, I'm thinking, all right, next year, you know, all people will get the flu shot over 65 years of age. So why don't I ask my nurse or get the GP to check someone's pulse at the same time they give the flu shot? You know, it's something simple, easy to do. And if you're getting about 80% coverage with your flu shot, that's a great way of actually assessing people for fibrillation. You know, tools like the audit tool for people who drink to excess, it's a very interesting process to watch them go through the actual questionnaire. And of course, then teasing out, you know, what they mean by answering some of those. And look, yes, it does take time, but like I say, we have those health assessment item numbers that are time-based, so you can actually allocate a reasonable amount of time to do this. And so the question that I have for everyone is, you know, is this something that you do as part of routine practice? Because if it's not, you know, we've got, you know, you'll be missing a lot of people who you can help there and then. And, you know, using those health assessments, you can make it, you know, quite financially viable. But it's all about how you identify people who you need to call in for those assessments and how you're going to get them to come in. And what I really would like everyone to do is just to think, you know, how you could actually go about doing it. Because, you know, the great thing about, you know, our journey through the Australian Primary Care Collaboratives was doing these things called Plan, Do, Study, Act cycles, or PDSAs. You know, you try something. You see if it works. If it works, it becomes routine practice. If it didn't achieve what you really wanted to achieve, what else could you do? And you just keep trying until you work something, you actually get hold of something that works for the whole practice. So, you know, my PDSA for the AF will be, you know, the problem, unrecognised AF in my practice. What am I going to do? Well, you know, how do I know if a success is a success? Well, I'm going to see an increased diagnosis of fibrillation, or at least an increased number of people who've had the quality of or the rhythm of their pulse assessed. And so how am I going to go about doing it? Well, my first thing is going to be, right, everyone who has a flu shot will have their pulse taken and recorded. You know, that's fairly straightforward. And then I can, you know, monitor that by looking at how many people have actually had their pulse checked. And I can look at the rate of new diagnoses of atrial fibrillation. And see, now we have such great medications to treat it. You know, to me that's going to be really exciting. I know I get excited by these things, but yeah. So then you can sort of, you know, move on and think, all right, well, I've got AF now, and that worked really well. The practice here works really well. Well, what else can we do? And you just sort of keep expanding until you've, you know, got each of the important things that you want in a progressive manner. Don't try and do everything all at once. It never works. So, you know, and of course there's ages and stages. So, you know, we have Rachel. You know, she's a 48-year-old vascular surgeon. You know, she's mother died of bowel cancer. Now, you know, we do ask for the common cancers on our questionnaire when people first come in. She had an aunt with breast cancer. You know, she's got a total cholesterol 6.5. You know, that's moderately high. A blood pressure, that's high. She's overweight with a waist circumference of 93, and comes in with poor sleeping. Now, you know, I look at that and I can see there's a huge amount of work to be done there. Now, you know, she may well have come in for a standard visit, and there are a few things I'm certainly going to ask about the poor sleeping. But when you think of her ages and stages and what sort of things that we should be checking, the list is actually quite large. So, how would you deal with this? Do your doctors have a process for, identifying people who are high risk for whatever, and then getting them to come back? So, for this lady, again, she's 48. There's enough there to say, well, I'm going to get her to come back for a health assessment, looking for chronic disease. That allows me, or the patient, to have, like I say, we allow 40 minutes with our nurse. So 40 minutes to sit down with the nurse to go through a whole lot of questions, a whole lot of measures. Then, 20 minutes with me to start talking about what we're going to do and her, where she's at, what her attitudes are. And, with that sort of time, you can often make a huge improvement in someone's outlook. So for her, is she up to date with her pap smears? In my previous practice, we had a, very multicultural practice. Less than 50% of eligible women had a pap smear between the ages of 45 to 55. And a lot of it's because it was cultural. But still, it's proven to be a very hard, nut to crack, so to speak. Breast checks. Now, she's not quite eligible for mammograms just yet. Mine aren't. The risk is not as high. So, but certainly, talking to people about their breast health, I think, is really important. Absolute cardiovascular risk, I'd be interesting to know how many people think she's at high risk and actually would start either a statin, a blood pressure tablet, or both, because we'll actually go through that later on and why it's really important to actually work out what the risk is. And it's the same with the OSD risk. This is a screening tool for diabetes, and look, I think she will end up scoring 11. So, she's just under that high risk mark. But, if you'd had a family member with diabetes, like a brother, sister, or parent, well, then she would tip over into the high risk, and you can refer to some of those prevention programs. She's female, approaching menopause, thinking about her fracture risk and the risk of osteoporosis. Is it in the family? Her mental health, remember, she's presented with, poor sleeping. What's going on? Is it long hours of work? Is it stressful work? Is she approaching burnout? So, again, to do this within a 15-minute consult is never going to happen, but to give the permission to do it as part of a broader health assessment, she may well be more open. So, in this particular consultation, we may be talking about her mental health and her problem sleeping. That's what she would be there for. But to then turn it back on her and say, look, there are a lot of things I'm concerned about with your health. How about we organise some protected time just to go through some of your general health issues? And, surgeon, working long hours, has she started using alcohol to sleep? So, using the audit tool, which is, an alcohol screening tool, would be a useful thing to do, or, just asking her about what's happening in terms of that. But you can see there's actually quite a lot. Now, she's healthy, so, part of the job then is to actually try and keep her healthy. And unfortunately, there's not a lot of support apart from these health assessments to be able to implement great health, interventions like this into practice. So, her absolute cardiovascular risk assessment. So this is freely available on the website. Just type in absolute cardiovascular risk, and it's cvd.check.org.au. Now you can see that her absolute risk is 2%. So 2 people out of 100 over 5 years will have a heart attack. With her risk, which is really quite small. And if any intervention, so giving her a statin will reduce her chance of heart attack or cardiovascular event by about a third, 30%, 25 to 30%. So it would go down from about 2% to about 1.5%. So, for her, we would then say, well, in fact, She doesn't need intervention for her blood pressure. She doesn't need intervention for her cholesterol at this point in time. And a lot of people find that shocking because, certainly when I went through med school, if someone had a blood pressure persistently over, 145, 150, we would treat. But in fact, they've worked out that the number of needed to treat to have an intervention at her age is actually quite large. And the trick now is to say, well, what is her total risk? What interventions would we do that would then improve that? And then when do you actually intervene? And to me, this lady would be a fantastic person to start talking about, at least once a year, we would touch base, repeat the absolute cardiovascular risk, and check to see how it goes. And the mainstay of treatment here would be around lifestyle, exercise, diet, and so on, and, lifestyle around stress. But, certainly there are a lot of doctors who would treat her for what she has, but in fact, treating her for what she's got will only, you'd need to treat 100 people for 5 years to prevent 1/4 of a cardiovascular event. So that's 400 people for 5 years to prevent one event. So, it's, if you put it in that sort of terms, a lot of patients will say, well, no, I'd actually prefer to do the lifestyle thing, which is, a different matter if it was like at 20%, where it's a 1 in 5 risk over 5 years. So these tools, whether you use the diabetes ones, the absolute cardiovascular risk, the FRAX tool, are freely available, and they're great tools to, I suppose, convey what real risk is to patients. Because remember, we are trying to convince patients who have no symptoms. And so, to make an intervention, we need to get them to appreciate what it is that they've got. If her risk was 20%, and I said to her, well, you've got 1 in 5 chance over the next 5 years of having some cardiovascular event, that's a big, big difference to 1 in 50. So then we can actually use that to sort of make changes. So with those two cases, that's very much an individual approach. And yes, we do manage to get some people through that individual approach. But, busy general practice, you're behind time, we often don't get the luxury of doing a lot of this. And so, to me, where you can make real gains is to think about how you do this at a practice level. So, we have data extraction tools, we have ways of looking at, our practice population, and then, to think, sit down with your whole of the practice and actually say, well, what is it that I really want to achieve here? So, if you start saying, well, in my new practice, it's a lot of mental health. In my old practice, it was very much about heart disease. So, it's what it is that you want to achieve, but you also have to look at what resources you have. So, at the moment, there's a huge deluge of asthmatics going into the emergency departments in Victoria. We've had hot days, we've had a thunderstorm, this happens every year. So, you may say, well, I've got a nurse that does a lot of asthma management plans. So, we could have prepared a lot of our patients for this. So, then you can say, well, what I might do is start with asthma or COPD. So, it's really about what it is that you want to achieve and make a start, because, if you're doing something that you're passionate about, that the whole practice buys into, you'll be able to achieve a lot more. And if you do it in a coordinated way so that everybody knows what's going on, you're supporting your nurse and your practice manager and your receptionist to identify things, then it will actually happen. And, I'll show you some graphs later on about the success of implementing things like some of the absolute cardiovascular risk assessments. So we know it can be done. And yet, so important, because if you think of Ralph and his journey, we all have patients who have had multiple problems, events, and, you know, once it's happened, it's really hard to rescue them, and much better if we can, you know, intervene as early as we can. And I'm not saying it's always easy, but even if you capture 10 or 15% of your population, you know for that group, you will have done incredibly well. And, you know, it is a practice-wide thing. If you're trying to do this as an individual within a practice, it is so much harder because, again, with the business and the cut and thrust of general practice, very hard. But if you allow protected time and resources to actually get this done, it makes a huge difference. So this is where it comes in about what people actually need to be doing. So, you know, you need to have staff to absolutely do this. So, you know, we're about to embark on our, you know, asthma service. So, in fact, you know, we're training up our nurse to do, you know, spirometry. We're getting her to be familiar with the asthma management plans and all those sort of things. So then we've got a solid base. Then within that, we'll take a whole practice on a journey with, you know, our receptionists, our nurses, our manager, and our GPs, all saying, well, we're going to target asthma. And this is what we're going to do. So this is what we can expect. You know, if you identify people who have asthma, you know, refer them into the service. And we know that the number of asthma management plans, especially for adults, is in fact very low, but they're in fact very good, and it would have stopped a huge number of people going to hospital if they would know that things like thunderstorm after hot days, they're going to get asthma. Really important is this protected time. And that's for, you know, the lead. So you may have a GP or a nurse taking a lead on this, or the practice manager, and you'll need to have time to absolutely put this in place. You'll need time for your nurse to actually plan what it is that they're going to do and how they're going to do. You'll need time for them to pull out the data and the statistics. And all of that will feed into a system so that basically everything happens seamlessly, from the identification of a person who has asthma or is smoking or, you know, whatever, through to the various interventions that you've put in place. Everyone knows what it's going to be like. There's no second guessing. It just basically goes through the system. They know when to make the appointments. They know they have these appointments to be used. But without that, so in my previous practice, I had a 6-week wait. So what we did was we had specific what I'd call health assessment care planning appointments, and they were always the last appointment, the first appointment after lunch, basically. So that way, you know, we knew it was there. We had an hour set aside, so there could be, you know, 2 health assessments, 2 care plans, something of that nature. But it was there because this sort of planned approach is really where you make a lot of the gains, you know, in terms of health and outcomes. And that comes down to ownership. So, you know, within our practice, so we've got a nurse who has a very big interest in lungs and asthma. So, great, that's where we're going to start because it's easy, and away we go. In our previous practice, we had a nurse who was really keen and interested in doing diabetes and, you know, the diabetes risk assessment. So, you know, she started putting out things like questionnaires so that anyone who came to reception, they were given the diabetes risk assessment tool. You know, and then she would collect them in from the waiting room. Now, notice she had to have time to be able to do that, but she would look at it and she would identify those people who are at risk, put a nice little highlighter on, so when they came to the GP would then say, oh, okay, well, this is really important, and then the process goes on. So how you do it is very much an individual practice, but it can be done, and you need to work out so it works for your practice and the way your nurses, GPs, receptionists, practice managers work. But that protected time, that planning systematic approach is where you make, because I can tell you, years gone by, we used to try and do it ad hoc. You know, it works great for a day or two, but then you get lost. So you need a system that basically is part of your usual daily routine, and so it just happens, because without that, it never does. Now, unfortunately, you only have a fairly small window of opportunity when it comes to support for health assessments in a true sort of Medicare sense. And so the main two ones in terms of assessment, you have the type 2 diabetes risk tool, which, they're 40 to 49 and at high risk according to the diabetes risk assessment tool, which is a score of 12 or above. You can then pull them in for a health assessment. And remember, the health assessment is time-based, and it also includes the time that your nurse is involved in doing that. And so, certainly for when I was working in Broadmeadows, again, a very low SES area, in terms of the time that you could spend with a patient, it certainly paid for the nurse and my time to start talking about doing an intervention. And if you did it well, it worked so well. And certainly the 45 to 49 sort of health assessment. And so anyone who's at risk of developing a chronic disease, that can only be done once in that age group. And again, the challenge here is how do you actually get people to come in? So, we tried sending out letters. Now, remember, 50% of our patients were multicultural there. English wasn't so good. So the return rate wasn't that great. However, if they came in for something else and the nurse would talk to them, or the reception would give them some, we're doing a thing on health, so here's some information to do your health assessment, or, ask the GPs to be aware of this particular age group, we found that we were actually getting far more people into it. But again, the key was that we had to have, time set aside for them to be completed in a reasonably quick time. So there was no point saying, oh, you're at high risk, we want to do this health assessment, but then we'll book you in 2 months' time. The messages are mixed. So again, this is why we had those spots specifically available for our nurses to book people in, or I could book them in if it was around, one of these health assessments. And again, it worked really well and allowed us to tackle this group of people who are at high risk. So, if you really want to make a huge impact on an area, because, when I first started my journey, I was really concentrating on my practice, and then I started thinking about, what's happening on the wider sort of field. And so, certainly over in SA, they've got that wonderful sort of table of, all the health issues and preventative health issues that occur across the regions. Have a look at it. Have a look at, what's actually happening within your local region. So we've got something similar in Melbourne or in Victoria. And I actually used a thing called the Heart Map. Now, the Heart Health Map was looking at avoidable presentations, in fact, all presentations for ischemic heart disease, heart failure, and stenting within the local area. And it just so happens that where my practice used to be was one of the highest rates of avoidable presentations for heart failure. Now, out of that, we decided, okay, we're going to look at heart failure within our practice and work out what we can do. And in fact, we had quite a high proportion of people with heart failure, older population, low SES, high smokers, high ischemic heart disease. And then we were able to work out that, in fact, only about 60% of our patients were on evidence-based medicine. And in fact, fewer than that were actually doing the lifestyle stuff. So, we had a lot of work to be done. So, we approached the local hospital and, he said, we were able to get a cardiologist to visit our practice to support the changes that we were doing in the practice to improve our heart failure program. And in fact, what's happened now is that particular thing is now being trialled in 4 practices, and then hopefully we'll go to another 10 practices next year. So it's amazing what you can achieve if you just take that slightly broader look and engage with what's happening around. So, think what you're trying to do and then look at the population and see if it's something that intrigues you. So, my next thing's going to be about secondary prevention, about someone who's actually had a cardiac event, trying to prevent the second. Because if you look at the stats, 60% of people having a stent have already had one before. So there's a huge amount of prevention that has to happen within that space. 15 to 18% of the population are still smoking. If you have a thing about cigarettes, we've got so many resources to help people quit. Sometimes it's just having the information there to give people at the right time. So, so having those resources available is really, really important. I know I'm sort of all over the place a little bit there, but now, this is what can be achieved. So this is the number of people who've had a diabetes risk assessment as part of one of our collaboratives. As you can see, the number actually having it done, grew hugely. Now, we know from trials that you can, roughly 50% in the actual trials, you can prevent 50% of people who are at high risk of getting diabetes over the next 5 years. If you look at some of that translational research, which was done by the Greater Green Triangle, they did it in real world and general practice, they got about a 40% prevention. So we know the interventions work. So we've now had all these diabetes risk assessments done. So there's a huge number of people that we know that we can delay the onset of diabetes hugely, just by identifying and then sending them to one of these coordinated diabetes prevention programs. So, and when you see that, you just got to say, what a fantastic outcome, because, diabetes, once you've got it, I'm sure many of you have seen like me that it seems to be this progressive deterioration, and they seem to get worse and worse. Although, let me say, with everything new, I always get excited by this. Things seem to be changing around a little bit, but certainly previously it was this progressive decline that people used to have. And certainly if you, again, this is the Wave 9, as you can see, huge increases. So just by focusing on what it is that you're trying to achieve, you can actually make a difference. So this is now looking at the cardiovascular disease absolute risk assessments, and as you can see, the number of assessments increased enormously. Now, even if you worked on 10 or 15%, or even 20% sort of uptaking some of the interventions that you were doing, that's going to be a huge impact on your practice. And remember, that's only a once-off thing. Certainly in our practice, we have a lot of patients who keep returning. We have a good continuity of care. You get more than one bite of the cherry. So yes, you can do this health assessment and get them underway. But again, organising a review, getting them to come back, getting the nurse to work with them, it's all really important. And eventually, some of them get it and can make a really huge, impact on their health and make us feel good as well. So again, these are some of the absolute risk assessments. So you can see they go up just by focusing. So, to me, doing something and then maintain the rage or keep it going is always the issue. Certainly I've done things in the past. I think when I first started in general practice, I had a thing about tetanus. Every year 4 people were dying of tetanus, which is purely preventable. And so I started immunising all those people who were born before 1960, because a lot of them had never had a primary course of tetanus. And so it was a joke that every time someone came to see me, they'd walk out with a sore arm. But if you look back now, there was this huge flurry of activity which lasted for about, 6 weeks. And then you could see that as we got busier and busier, it started to drop off. So again, how do you put something like that and keep it into the system so that it doesn't fall off the page. So, and part of that engagement is regular reports on how things are going. So, looking at immunisation rates. So, if you're talking about childhood immunisation, put up graphs of what proportion of your children are fully immunised. Certainly in the Broadmeadows area, we were much lower than the national average and certainly nowhere near where it should be. So, again, putting up graphs saying, well, we're not doing so well, what are we going to do? And then with time, seeing those graphs change can be quite a powerful motivating. So, certainly publicising the change and celebrating achievements. In our practice, we went from 15% with an A1C greater than 10 down to about 3 or 4% over 2.5 years. Fantastic outcome. Patients loved it. Oh, not patients, sorry, the doctors loved it. But, where it really improved, it was, a whole of practice approach. We had our receptionist, we had our nurses, we had our manager, and we all celebrated that success. We talked about it, we put up the graph, and that sort of motivates people to keep on doing things and also being involved in other things. And then, remember the PD, I know SA is not South Australia, but keep doing the PDSAs because try something. If it doesn't work, don't stop there, try something else. And if you're still not certain, ask other people, other nurses, other practices, because let me say, people have tried and had some success in this, and there's a great little spot on the Improvement Foundation website where you can actually look at what people have done in the past, some of their PDSAs, and well worth a good look because there will be something in there that will really intrigue you and make you want to do it. So look, I'll leave it there because, I will now let Amy take over the presentation and open up for any questions.
So, Ralph, I've got a question for you. How did you find that your patients were willing and able to go to some prevention lifestyle risk modification programs? And did they go until the end of the program? What was the kind of compliance rate?
Okay, so it was interesting. For diabetes, in Victoria we have a specific diabetes prevention program, and it consisted of 5 sessions and then one later on. Now, once, so with that, what made a big difference was that as part of that funding, Allied Health were funded for a first visit one-to-one with the patient to talk to them. And that sort of gave the person a link to who was running the program. And with that, then they were far more likely to attend the program, so that personal relationship. Once they got there, it was something like 70% would attend at least 4 sessions. But you're right. Again, a lot of people felt quite threatened about being told it was a group session, and prior to that individual visit, a lot of people just wouldn't go because they just felt too threatening. And we had something similar for people. We had a local gym doing a program called Lift for Life, and this is again for chronic disease. And look, I had, 25, 30 people attend that. The difference, and what made it, is that I knew the name of the person individually, and so I would then write a letter, but I would actually tell the patient, I want you to go to our local gym, I want you to ask to speak to, give her name, and she will see you. And that personal, a recommendation made the most difference because, they had a name, I would be telling she's a lovely person, and it would give them the confidence to go, into a place maybe where most people would fear to go. And so, look, I had, like I say, 30 people, who had diabetes, hypertension, all that, going to this program, and they bonded as a group. It was funny to hear people talking about other people at the group, and then recognising that they're actually talking about different patients of mine, and they got to know each other, and it worked really well. So it's all about that personal touch. And so knowing your resources and where to send people, but giving them that comfort. And then, I'd often tell, her name was Annie, I've made a referral of such and such to you. And if they didn't turn up within 2 weeks, she would email me back. So next time that person came in, I say, I see you haven't been to the gym program, what's going on, a bit worried, a bit frightened, and then explore that whole reason about why they didn't go in the first place, because, it's never just a once-off. This is a progressive empowerment and engagement of people. And the beauty of general practice is we do have our patients here for the long term, and we can keep we have more than one bite of the cherry, so to speak.
We're a bulk billing practice, and it's very difficult from a financial point of view to assess and manage cardiovascular risk within the MBS related to the age group of those at risk or early risk. What are your thoughts, and do you have any suggestions on maximising MBS?
Certainly. So, if you would have seen that slide, if you've got people at risk of any chronic disease between that age of 45 to 50, I think it's actually quite lucrative. So, if you sit for more than an hour with someone, it's over $200, and that will certainly pay for both your doctor and your nurse time. But as I said, outside of that 45 to 50 age group, you're right, it's actually incredibly hard. And so if you're talking about someone who's basically got no chronic disease and it's pure prevention, you're right, you have to do it basically on your attendance items, which does not suit prevention and the way we'd like to do things. So really, it's, again, multiple bites of the cherry with small takes. So, certainly, with the rebate freeze, it's becoming harder to do longer consultations. But, I don't know if I should say this, but sometimes if you had someone who came in and you're dealing with one thing, but if you then tacked on a little bit about prevention, and you went from a level B just to that level C to around, 22 minutes or whatever, in fact, it does make sense. It starts to make a little bit of extra income because because that level C is such a wide gap, you can take a level B after you're finished with your consultation, but then concentrate on the prevention stuff to then turn it into a level C. And that will give you a little bit of extra income. But I agree with you. The funding for prevention really does need to change and be made much more available to our younger cohort, because all these diseases are happening earlier and earlier. And I think of things like the bowel screening. We know it's one of the most effective screening programs in terms of prevention of cancer. But, they have engaged with general practice really well, and there's no specific funding for GPs to take a role in this. So, of course, there's, only 30% of people are doing it. Well, they need to get their act together and really understand how important and how much influence general practice can have in this. But, no real answer on that one.
No, all good. Thank you.
As I mentioned at the beginning of today's session, this is the first in a series of 5 webinars. This was the third in the series of 5 webinars. We've got 2 more coming up over the next 2 weeks. So next week, at the same time of 1 p.m, Australian Central Standard Time, we have Prashiba Thavarajadeva, who has more than 8 years' experience in primary care, and he is the business manager and director of 3 practices in Adelaide. He previously worked in the corporate sector in telecommunications and finance, and is also a qualified engineer. Prashiba has many innovative ideas regarding engagement of patients in prevention activities, particularly with the use of technology and social media. So really worth having a listen to Prashiba's presentation next week. And the one the following week, nurse clinics. and that's being presented by Ros Rolleston. Ros is a primary healthcare nurse and educator from Nowra in New South Wales. She has a wealth of experience in both the acute and the primary care sectors and is just about to finish her Master of Nursing. Earlier this year, Ros began a new role as the Skip Into Life project manager at Warragee Medical Centre. Skip Into Life is a nurse clinic for people with mental illness as well as physical limitations. And so Ros will take us on the journey of how she instigated, set up and is evaluating her nurse clinic with the support of a whole of practice approach, as Ralph has discussed during today's presentation. So if you haven't already registered and you would like to, please go to the Improvement Foundation website, improve.org.au, and click on the link on the homepage. And please do encourage any colleagues you have who you think might be interested in either or both of these webinars. We have spots left for people to join. Okay, so thank you so much everybody for coming today and attending the webinar. We really appreciate your time. Thank you very, very much, Ralph, for taking the time out of your busy schedule to chat to us today. And I'd just like to acknowledge that SA Health have funded this webinar series. So thanks to them. Have a good afternoon, everyone.
Thank you.
Bye.
Bye.